probably noticed healthcare in the news. You've probably noticed healthcare in your paycheck. Healthcare costs more and more, and I want to talk a little bit about what we've learned about that and what we can do about it, mostly what we've learned. So I'm going to start off my talk by talking about U.S. healthcare in comparative perspective, and just to set it up for you, I'm going to talk about the cost of healthcare, which I'm going to measure in spending per person in constant US dollars. You'll remember inflation from your finance classes, right? So we're going to correct for inflation, we're going to use US dollars, and we're going to look at outcomes, and I'm going to focus on male life expectancy at age 40. Why male life expectancy at age 40? Most of you haven't hit age 40 yet. Everything is downhill from there. That's when medical care really starts to kick in and when you stop having fun. So it's a really clean measure of the effectiveness of a healthcare system. So I'm going to talk about that a little bit, and then I'm going to talk about what we know that explains US performance, and I'm going to give you a really novel theory that's actually starting to catch on. It's really very controversial and interesting, and see what you think about it. Okay, so let's start off by talking about the situation of the US healthcare system. This is data from 1976, and you can see the United States there in purple, nestled among all the other countries of the OECD, among all the other rich countries. I want you to watch the United States, and I want you to watch Australia. What do you think of when you think of Australia? Do you think of Crocodile Dundee, right? I mean, Australia, well, they don't have any guns, although they did back then. They did back then. You know, it's not like France and the Mediterranean diet or anything. It's Australia, right? So you watch the US and watch Australia as we move along over time. Here we go. Here's 1986. US is pulling a little bit away. Australia is still there, nestled in the bosom of the rest of the countries. Things are getting a little more expensive. You see male life expectancy improving across the board, all those countries doing better and better. Australia is still there in the middle of all those other countries. There's the US. There's 2006. And here's 2016. Okay, so notice that all those other countries still remain really closely clumped, both in terms of costs and outcomes. If you know anything about their healthcare systems, they run dramatically divergent healthcare systems. Their healthcare systems don't resemble one another's at all. Australia has lots and lots of private health insurance, for example. But they look really different than we do. They've had a very different experience. So if we look at this data and look at the United States, what you'd say is, look, we're doing a lot better over time. Male life expectancy at age 40 has really improved, and we're spending more over time. We're spending more and we're getting more. Not so bad. But if you look at all the other countries, what you'd say is, well, they're spending less more and they're getting more. So there's something wrong here, okay? So what can we say to sort of summarize our plight? Back in the 1970s, even in the 1980s, we used to look pretty much like everybody else in the world. There's nothing dramatically different. And if you think about why or whatever, you got to remember that back in 1980, we looked just like everybody else. But since then, we do worse and we spend way more. Something's gone wrong. So what is it? Well, I'm not going to spend any time on this except to say that the usual suspects turn out not to matter. It's not obesity. It turns out the second most heavy country in the world, whatever the right term for this is Australia. Okay? So they've got the same problem, but they didn't have the same reaction to it. It's not smoking, it's not violence, it's not traffic accidents. Those things were much worse in the US in the past. They've gotten better, right? So we ought to see some improvement, relative improvement there. We're not seeing it. It's not end-of-life care. That turns out to be a complete non-issue. Okay, so it's none of those things. And it's not that we are gross overutilizers of care. There's the US and the flags, and you can see we actually don't go to the doctor very much. Not surprising, we all have these high deductibles and it's all these uninsured people. So we don't go to the doctor as much as people in many other countries. We don't go to the hospital. We don't go to the ED. I'm not showing that to you. We don't have long length of stay. It's not utilization. Turns out it's not that we do a terrible job running our hospitals. No, go Wagner. We have the best hospital managers in the world, okay? We do really well here. That is not our problem. So what is it? Well, that's a guy named Uwe Reinhardt. He just died last year. He was one of the most famous health economists. He wrote a paper back in 2003 called "It's the Price is Stupid. Why is the US so different from other countries?" People have followed up on this. We have too. And this is the most recent of these papers in 2018. It's the prices. The prices of everything in the US healthcare system are much higher than in other countries. You can kind of infer that. You saw our spending is really high. Our utilization is not really high. If the spending is high and the utilization is not high, it's got to be the prices, right? Okay, but you can also look at the prices directly. This is just estimates of how much things cost in different places. And look, you know, these are places where cars cost about the same as they cost here and houses cost about the same as they cost here, but not bypass surgery and MRIs and things like that. Those cost an awful lot more in the United States than they do in other countries. Our prices are just way higher than anywhere else. So what does that mean? Well, the question is, why are our prices so high? And the story people have told for a long, long time is because our costs are high. It just costs a lot more money somehow to produce health care. We don't know why, here than in other places. But here's a more, and so if you think that's the reason, you say, well, you know, it's because we have all these insurers, these competing insurers, and billing documentation and all this nonsense, right? And if we could just get rid of all that, we would look like the other countries. But I want to conjecture something quite different and say maybe the direction of causality goes the other way. Maybe it's not that our high prices reflect high costs, but that our costs are high because our prices are high. What do I mean by that? How does that work? Well, here's a story about what happens if your prices are high. What happens to that money? What does it make you do? Well, one possibility is it just goes into the shareholders of healthcare companies. They're mostly nonprofits, but we'll forget that. It's just surplus. But the three more complicated stories are when the prices are high, you have incentives to do new things, like invest your surplus in technology to attract more high-paying patients. You've seen all those signs for, you know, the latest gizmo, the latest healthcare gizmo, come to our hospital, we've got it, right? Second possibility is you bid up the prices of the scarce resources, the people, doctors, and nurses who serve those patients. A third possibility is you just increase the incentives, you increase your service intensity, you have more people getting people through the hospital, you have more incentive to improve coding, to get your bills paid quicker. Let me show you how. So imagine that you have a healthcare administrator, and that administrator gets paid a salary of $40,000. Let's look at two scenarios. The low-cost system, a sick patient costs, say, $500, and a very sick patient gets reimbursed $1,000. So if you could have an administrator whose only job was to upcode patients, to find some reason to make that insurance company pay for a very sick patient instead of a sick patient price, do you know what I mean? Right? You'd make $500 per patient, and it would take you 80 patients to pay off that administrator. They'd have to upcode 80 patients. But if the difference is $1,000, you only need 40 patients to upcode that administrator, to pay for that administrator, right? And so there's an incentive to hire twice as many administrators when the prices are twice as high. Do you see that? It's going to work out in that way. So we actually have done some analysis with some recent Wagner alums to look at where the money in the healthcare system goes, what's happening with it. And this is some recently published work. The first question we ask is, does it go into higher surplus? Are people making more money off the system? And what you see here is lots more money is going into the system. The solid lines are the money going into the system. The dashed lines are the expenses. And, you know, both lines are going up. But the percentage difference between revenues and expenses isn't going up. That is, it's not all just going to the shareholders of healthcare companies, which would be hard because they're not-for-profits. It's going other places. It's not just going into surplus. So where's it going? We looked at where it goes. The number one place it went between 1997 and 2012 is into purchases of technology and products and other things that get used within the healthcare system. And the number two place it went to is the compensation of doctors and nurses. So they're doing a lot better than they were in 1997. And when we break it out by which salaries in the healthcare system are higher than you'd expect, again, it turns out that doctors and nurses' salaries are much higher than you'd expect, but administrators and other kinds of people who work in the healthcare system don't make any more money than they would if they were working in some other sector. Instead, what we're seeing is we just hire a lot more of those people over time. So you can see we've hired a lot more healthcare practitioners, non-physician nurse people, a lot more support occupations, a lot more IT people, just as I'd expected. When you have an incentive to be rolling people through the hospital ever faster, you keep hiring more and more of these folks. And that isn't happening in other countries. This is the share of the labor force employed in healthcare. And you can see here that in most of the other countries we look at, that number has been pretty flat. Whereas in the US since 2000, which is as far back as we can go with these data, it's been increasing pretty steadily. So we have more and more people employed in the healthcare sector. So what do we know? High prices look like they actually generate higher costs by giving people incentives to make investment decisions, to make pay decisions, to make hiring decisions. And that's going to be a really tough problem to solve because fixing the administrative cost buying a new billing system is not going to get rid of costs in the healthcare system if the incentive is coming from the prices. We're going to have to go after those prices directly. So that's where the research stands right now. Thank you.